So, our next segment, we're going to talk about treatment and recovery from ACL injuries. So, how is an ACL treated? Is it always surgery? Is it reconstruction, or there's much in the literature now about repair or this bare procedure?
Yeah, it's a great question. I always say there's always two ways to treat anything, right? You can do it in the what we call non-operative way, and we can talk about which patients are eligible and ideal for non-operative treatment.
Hmm.
And obviously, most people know that most people who have ACLs end up with ACL surgery to either repair, but most commonly to reconstruct or make a brand new ligament. And I think that's really critical to understand where you may fall even before you see a surgeon or a physician, because that will help you understand why they're explaining both options. And really, the for a non-operative person to be successful, they have to have a stable knee. That's the ultimate goal of
Hmm.
any of these treatments, whether it's surgery or no surgery. The ultimate goal is a stable knee. If your knee is unstable, if it's giving way, you're at a much higher risk of tearing those shock absorbers that you talked about, which are the meniscus. And that's what's going to lead to arthritis long term. And that's our ultimate goal, is to protect your knee for as long as possible and give you a knee that works all the way through your whole life. So that's the ultimate thing that we look for, is stability. And if you have a stable knee and you don't do cutting and pivoting sports and you're older, you likely don't need an ACL. And if you don't have a stable knee, even if you're 71 or 80 or whatever it is, if you can't twist and turn to get into and out of a car without your knee buckling, or
Hmm.
even, going to get something from the refrigerator, we call that daily instability. And it really doesn't matter how old you are. If you have daily instability, you need to have an ACL reconstruction. If you have what's much more common, which is called sport-related instability, and you don't do cutting or pivoting sports, then you can probably get away without it.
Yeah, I similarly have the same conversation with patients. They tell them there's two different ways to treat everything. And I think the patients that can do well with a stable knee with non-operative management I call it inline sports. So you're a runner, you're a cyclist, you like to do classes at the gym that don't involve a lot of side-to-side jumping, a lot of side-to-side movements, and those patients can do quite well with non-operative treatment. Their knee is stable once they build back, like you were saying, the muscular stabilizers, the knee itself. You build up your endurance, you build up your strength, and you can get back to pretty much whatever you want to do. And I think some people can even get back to skiing, even though we said skiing is an ACL tear risk factor. If you happen to have an injury, people can get back to sports like skiing with non-operative treatment, provided they do the rehabilitation, kind of build their strength back up, build back their endurance. They can get back to sport that they desire. With the caveat, if you cannot, there's always reconstruction as a backup, but we don't always have to jump into surgery in a certain patient population.
And I think that's an important point, because that decision doesn't have to be made on that first visit to the surgeon or to the doctor. Going through a course of rehab is really important to see if this individual will cope without having an ACL, or they will need to go on as they get their muscles stronger and they learn different neuromuscular techniques.
And two things on that. Patients always ask, will I need a brace? Will I need a brace if I'm living without an ACL, if I'm choosing not to have surgery? And the answer for that is the brace itself does not prevent another
Right.
injury, but it can actually help in terms of connecting your brain with your knee, what we call proprioception, which is your brain's ability to observe your body position. So knowing where your knee is, or knowing where any joint is extremely critical for your brain to make split-second decisions to protect your knee, especially if you're doing sports. And sometimes a brace can be helpful with that. So we actually ask patients, to try it, and usually during those high-risk cutting and pivoting sports, if they're choosing non-operative management. And sometimes it works, and sometimes they don't need it. But that's really a patient-level decision, and oftentimes with their physical therapist, based on how they're moving.
Especially if they want it,
Yes.
then
Yeah,
that's
sometimes that's their brain telling them they're more comfortable with it. But again,
absolutely.
that is the far lesser percentage of people who tear their ACLs, or those that are managed without surgery, and the far more common is surgical management of or ACL tears. And so, Dr. Q, do you want to talk about the types
Yeah,
of
so there's
surgeries?
definitely, like Dr. Shubin Stein said, there's a subset that we can discuss non-operative as an option, but there's a subset that where we really recommend surgery when we see them, and that's the young athlete. I mean, even up into the 20s, 30s, somebody who wants to remain active. Obviously, a cutting, pivoting athlete, we're going to recommend surgery at the initial visit, because we know from the studies that an untreated ACL tear, meaning persistently chronically unstable knee can lead to meniscal injuries to the shock absorbers, cartilage injuries, which really complicate your recovery. It does add to the surgery when we do go in, and it leads to more damage to the knee. And so we're trying to prevent any further damage. We're trying to prolong your knee longevity, get you back to activities pain-free and as quick as possible. And so the subset of patients we recommend ACL reconstruction are those young, active patients. There's, like you were mentioning, a multitude of ways to discuss ACL surgery. The most commonly discussed in the literature and performed by orthopedic surgeons is ACL reconstruction. So we borrow tissue from somewhere in your body or from a donor. They're called grafts that we borrow from your knee, and we reconstruct your ACL. We create you a new ACL, and then the body takes it over, and it becomes a ligament. So we can talk about the different graft options. So there's 4 that are commonly used. The first one is called bone-patellar tendon-bone, and what that means is we take a central slip of the kneecap tendon that connects the kneecap to the shin bone, and we take the central third of it and a piece of bone on each end. And that's probably the most common graft in America. The most common graft used across the world is the hamstring graft. And so hamstrings are the muscles in the back of your thigh. They reattach to the shin bone, and we borrow 2 out of the 3 at the shin bone, and we whip that into a graft, and we use that to replace your ACL. The quadricep tendon is the other kneecap tendon, so it connects your thigh muscle to the top of the kneecap, and that's a newer graft over the last 10 to 15 years, but it's becoming more popular. That one can come with or without bone on one of the ends. And then the last one that we borrow is from a donor. So a donor means somebody who has donated their body to medicine. We borrow a tendon from them and, again, whip an ACL graft out of that. And there's different indications for each graft, and we always present them to our patients, and I think a graft choice is a patient-surgeon decision. There's not a graft that's used for every single patient. It's always a discussion on the risks and benefits of each graft. And I think we can discuss that.
And I think the rehab differs a little bit, especially early on, so that may impact somebody's decision on, what graft they want to have, as well as what the surgeon is comfortable doing, I think is an important thing.
So that's a great intro, because when I speak with a patient, when somebody comes into my office and I've said you have an ACL tear, usually they know by the time they come in, and that's why they're coming. I have this conversation with them because I think it's really important to understand. And one of the things I tell all the fellows, and Michelle might remember this from many years ago, is that you should be an all graft surgeon. I really truly believe that every surgeon should do all the grafts and be comfortable with all of them, because then you're choosing the right graft for your patient, not the right graft for you as the surgeon.
Sure.
But that being said, there are surgeons who are
Absolutely.
very comfortable with hamstrings, and they should be doing hamstrings. You don't want to go to a hamstring surgeon and have them do your patellar tendon. Just like you don't want to go to a bone tendon bone surgeon and have them do a hamstring. They are different. They have different techniques. They all work really well. So that's one of the things I think we should say, and I try to say this all the time to the patients. All grafts work very well when they're done for the right reasons. The graft that we choose not to use specifically for younger patients is allograft. So that's donor tissue. And we choose not to use that because one of the first and one of the best multi-center outcome studies that we have by a group called MOON is a study that really showed us that there's a significantly higher failure rate when we use donor tissue in young patients. So young patients should have their own tissue. But once you hit 40, even in your late 30s, if there's a good reason to do it, donor tissue works beautifully. And one of our attendings here who trained me and who's wonderful, Tom Wikowitz, used to always say, the benefits are pretty much the same. People get back to sport and they do very well overall. It's which risks are you willing to accept, because each graft comes with its own risk profile.
So the gold standard seems to be the bone-patellar tendon-bone for a high-level athlete. Why is that?
BTB, or patellar tendon, is the gold standard for a very specific group of patients, which is a young high school or collegiate pivoting athlete. And I think that's really, when we say gold standard, sometimes that's misinterpreted. If you do a 38-year-old soccer player who plays soccer once a week with a
Right.
BTB, I'm not sure I would pick that. It really depends on
Sure.
what they do the rest of the 6 days a week, right?
Right.
That's the other part that you have to consider as you get into somebody who's older. But BTB, or patellar tendon graft, has a slightly lower re-tear risk than all of the other grafts that Dr. Q mentioned. And so for that reason, if we have somebody who has a high number of hours at risk per week, which is the 3-season, 2-season cutting and pivoting athlete, they have just more hours in every week that they're at risk. And so that slight slight decrease in re-tear rate means something, and that's why we tend to call it the gold standard.
So before we move on to our next section, let's talk about the other graft choices. So we have hamstring, we have allograft, we have quad tendon, and certainly the bear. So Dr. Q.
Yeah, so starting off with the hamstring. So the hamstring is probably the one that has the most literature to support it. Like I said, it's used worldwide at all different levels of athletes. And so it has, like I said, we take 2 of the tendons from the inside of the thigh and kind of whip it into one of your grafts. The main risk factors of that are people have sometimes noticed some push-off strength. So say you're a sprinter and we take your hamstrings. You're going to notice push-off strength as you're leaping off the blocks. And so again, a consideration for somebody who's a sprinter, we'll discuss a different graft type. We always tailor it to their patient and their activities. Regarding the quadricep tendon graft, like I said, it's a newer graft, and so we take the central third of the kneecap tendon above the knee. That has been shown to be an excellent graft. It's very thick, it's very robust. It's a much thicker than its sister tendon, the patellar tendon, and so the complications associated with that one are usually twofold. One of them, it's a very big graft. So if you're a small patient, patients do get stiffness in their knee, and something called a cyclops lesion is a complication of an ACL surgery, and that's when there's tissue or scar tissue that forms in front of the graft. And so people notice it when they're trying to extend their knee all the way straight. They aren't able to. They feel something in the front of their knee, and that's usually a cause of there's too much tissue in the knee. The knee sees the ACL graft and it reacts to it and starts to form scar tissue. And so that's a complication from the quadricep tendon if it's too much tissue inside of the knee. It's a concern for surgeons. We want a lot of tissue. We want a strong ACL graft, but you also don't want to obviously have stiffness in your patients afterwards. And the second consideration for a quadricep tendon graft is that the quadricep muscle doesn't really enjoy being bothered. And so patients do notice a slow ramp up or slow recovery of quadricep strength and activation. That's one thing we really focus on in rehabilitation. I know you do a lot with your patients on quadricep activation immediately after surgery. If patients try and do it at home, if you're sitting with your leg out straight, just try and tighten your muscle. And a lot of patients can't do that after quadricep graft. They notice the brain-muscle connection really isn't there anymore. The quad graft can really affect that connection. The muscle doesn't like to be bothered. And so that's a slow ramp up that usually begins to equilibrate as they progress their rehabilitation. But early on, that's one consideration when you discuss graft options with your patients.
And I would just say here that quad has a really good place. I think we're learning where that is. As Dr. Q said, 10, 15 years ago, it kind of came in as a new graft that we could think about. And so we're trying to figure out kind of where are those boundaries, where are those, bookends. And I think for revisions is where I started using it, because in revisions, oftentimes you have what we call tunnels that have been previously done through because of your previous ACL. And we want enough tissue to fill those tunnels, and that makes the surgery outcome better. And so quad works really well for revisions. And so we've really started using it. It's been used now for probably 10 years as primaries, and we've gotten better at it. But I think as Dr. Q talked about, what patient is the perfect patient for a quad is really where we're trying to land right now.
Yeah, that's an interesting point, because if they have failed for some reason, disrupting the quad mechanism again is from a physical therapy standpoint is really challenging.
And that brings us back to even discussing, and this is a discussion that everyone should have with their surgeon, if you're talking about a revision ACL, oftentimes surgeons will think about going to the other knee, the contralateral or opposite healthy knee, to take the tissue from. And that way they're not doing a double injury, taking the tissue and doing another ACL. But there's controversy on that too. So there's pluses and minuses to everything.
Does the fixation come into decision making with you? So I don't think we touched on this enough, but the fact that a hamstring is a soft tissue procedure where a bone-patellar tendon-bone, by virtue of its name, has bone plugs. So does that go into decision making? Besides the graft strength, so to speak, the fixation.
I think that is a consideration. Like Dr. Shubin Stein mentioned, we drill tunnels to get the graft to sit where we want it to anatomically. And I think it makes us feel good as surgeons where we're putting bone inside of bone. Bone heals to bone very readily. And so does the hamstring graft or the quad graft really heal, or does it heal at the aperture, the opening of the tunnel? And I think one of the things, the literature in the primary, the biomechanics or the kind of movement data that we have is that the hamstring graft, like I said, we whip it up together. And so multiple strands are being pulled across, and is each strand being pulled the same amount? I think that that's one thing in
Interesting.
hamstring literature we noticed that the strength may not be equal as to the one single tendon graft that we use because each strand is being pulled at a different
Mm.
rate, and that might affect the outcomes of the stability of the knee when we're whipping together a hamstring versus one single block of tissue from the quadricep or the patellar tendon graft.
Interesting. So we've kind of tackled the reconstruction, and now the next thing is repair. It's a lot in the literature. It started with the repair, and now we're hearing a lot about the Bair procedure. Dr. Q, can you comment on those?
Definitely. So, like you mentioned, ACL repair has been around for a long time, and it kind of waxes and wanes in popularity, and the outcomes also wax and wane. And so, what repair is we take the ACL and we put it back where it belongs. Primarily, it comes off the thigh bone or the femur, and it's placed back. But the concern with the repair is, does it heal? We know that the ligaments in the knee are bathed in what's called synovial fluid. So every joint has some fluid inside that helps lubricate the joint. And we know that synovial fluid does not let ligaments heal. So another example is when you tear your MCL or the inside ligament, if you tear it off the shin bone, the fluid can start leaking down. And so we know that doesn't let it heal. So we know that there's a risk of not healing when synovial fluid is a factor. And so that was the initial concern with ACL repair. Do these ligaments actually heal, or is it more scar tissue? How stable is this scar tissue? Do we feel comfortable releasing someone to a cutting, pivoting sport when we don't know the stability or the healing capacity of this ligament? And so a very smart researcher, Dr. Martha Murray, came up with what's called the Bair procedure. And so the Bair procedure is an augmentation procedure. So it is an ACL repair, but she devised a bovine collagen or cow collagen implant that is added to the ACL repair. And her studies, both in the lab, so in the basic science lab and in patients, have shown that it does augment the repair, with studies showing that it does help heal the ACL. So that is a new procedure that's out in our literature being studied to augment our ACL treatment options. I think we do have some early data showing some promise in this ACL repair realm, but I do think that the majority of surgeons do feel more comfortable with an ACL reconstruction, particularly in the high-risk population. Like Dr. Shubin Stein mentioned, the number of hours at risk, I do think reconstruction is still going to be considered by the majority of surgeons. We know the outcomes. We have significant long-term data supporting the outcomes of ACL reconstruction, with some promising data with the Bair for a more specific population, primarily patients a little bit older, less hours at risk, but it is being applied to that higher population, and we will keep a close eye on literature to see future broader applications of the Bair procedure.
Does the type of tear influence your decision? Like, does the Bair need a specific type of tear, or anybody who comes into the office with an ACL tear is eligible for a Bair? Is that
So as Dr. Q mentioned, it typically the ACL it's attached to both the shin bone or the tibia, and then at the top it's attached to the femur. Most ACLs do tear off the femur, but where they tear off the femur
right?
is critical. So if it comes right off the bone, then there's enough of the ligament left there to reach the bone as we try to reattach it. If it's further towards the middle of the graft, there's just not enough length in the tissue. So it does have to be a very specific type of tear to be eligible for repair, and then a Bair, which is an augmentation of the repair.
And I think just to mention the attractive nature of the Bair is the thought is that it's not disrupting a part of somebody's anatomy, right? So maybe the quads come back quicker, as opposed to a quad tendon, patella tendon, and I think that's still,
Well, several factors in that, right? When we're doing ACL surgery, when we're using your own tissue, we're actually doing two surgeries at one sitting. It's all at the same time, but we're first harvesting the graft. That's the real disruptor in
Right.
general of the quad or the extensor mechanism, which is the quad, the patella, the kneecap, and then its tendon below. And that's what really prevents that quad muscle for coming back as readily or as quickly. Certainly any surgery, even a simple knee scope will do it, but certainly when we're harvesting a graft from that knee, that's a double hit. So I think when you're doing a repair, you're not having that second surgery, and that's a big advantage, especially to the brain's perception of the muscle muscle and ability to communicate with the muscle, which we talked about being what we call neuromuscular connection or proprioception. And so that's significantly less disrupted in a patient who's having a repair versus a reconstruction.
And similar to the allograft, where there's no disruption from someplace else. But I think the key is they feel better generally with the allograft, but you have to go slower because it's not their own tissue and it has to be able to incorporate. Another topic we want to touch upon as we're talking about reconstruction and graft choices, et cetera, is the LET to supplement a graft. So do you want to discuss that, Dr. Q, Dr. Shubin Stein?
Yeah, sure. So what is an LET? It stands for lateral extra-articular tenodesis. And so we take a strip of your IT band or this thick tissue along the outside of your thigh. Again, the literature has waxed and waned over the years. This is not a new procedure, but recently it's come again into favor as a check grain or support for an ACL graft. We whip it around the LCL to provide some extra stability to our ACL graft. And there's many different reasons why we do this. And a lot of the literature now is investigating when and why we need to use an LET. And I think we primarily use it now in revision or redo ACLs. You tore your ACL graft, and one of the reasons might be you needed some more support. We look at all hosts of different factors, whether it's the way that you stand, the way that your bones are made, to identify risk factors of why you tore. But literature does show that adding this LET supports the graft. And so it's definitely used in revision settings, but can we use it in primary or new ACL tears? And a lot of literature is now coming out to investigate when we can do that. And it's still a small subset of patients that I think fit that criteria, but some of them include patients who are, like we mentioned, or ligamentous lax, or very, very loose. If we're in the operating room, and we always do an exam when you're asleep, when you're not guarding or protecting your knee, and if your knee is very loose, then we worry that the ACL graft can support it, but it might need a little bit of help. And so we can do the LET in that setting. Some surgeons are advocating it for patients who, again, have a lot of hours of exposure to support the ACL graft. So a lot of different factors are being borne out, with some new literature coming out in the next couple of years to really help us identify the best patient for a primary LET, but we definitely use it in revision settings.
And then I would also augment or add to that we have a study, the first randomized study, which is called Stability 1, which came out, which was done in Europe and in Canada. And that study looked at hamstrings, because that's the primary graft that's used in those countries. And it looked at hamstrings done alone or randomized with hamstrings that were done with a LET, or lateral extra-articular tenodesis. And there was a significantly lower re-tear rate in the group that had the LET. I think that's where we started to think about what other patients besides just revisions. A revision is most of the time done with an LET. That's very standard. But I think as Dr. Q mentioned, trying to find which other group of patients. There's an obvious group that are extremely loose jointed on the very far end of the spectrum in terms of how lax or loose they are. If a knee is extremely loose, you're going to put in an extra graft, which is that LET, to help stress shield or protect the ACL from stretching. I think in contact athletes or in cutting and pivoting athletes that play for a long time, every season, 2 to 3 seasons a year, I think we think about that, as Dr. Q mentioned, and I think we're really trying to figure out what is that high-risk subset that we can augment that will help, and that's where the Stability 2 literature will help us decide, as it's examining more than just the hamstring graft. It's also looking at patellar tendon and quad.
As we close this segment, I would be remiss not to stress the importance of rehabilitation. So I think we focused a lot on graft choices and risk factors, and it's really important that no matter what graft we use, surgical, reconstruction or repair, complete rehabilitation is so important to prevent or minimize the risk of a second injury. And we've grown from probably in the 80s, where we used time as a factor. Okay, 6 months, the knee feels good, you could go back. Now we're looking at other factors, and going through complete rehabilitation is so important.
So first of all, amen. I agree. I'll give you the amen on that one. I think the other part, just to add to that, is that It's not just to prevent re-tear, which is certainly our number one objective, but patients can have pain after these grafts. They can struggle with getting back to running and getting back to their cutting and pivoting, and that really is completely based on their therapy. How well did they do with PT? How did their
Absolutely.
therapist address their imbalances in their muscles? How well do they
Yes.
land or move, what we call quality movement? How well are they moving compared to the other leg? And I think that really is 100% based on the quality of their physical therapy and rehabilitation.
Absolutely. We don't just want to prevent, we want to get them back to what they want
Yeah.
to get back to, for sure.